Good morning or afternoon, everybody. My name is Suma Hoffman, and thank you, Dr. Junaid, for that lovely introduction. And my hope is that we, by the end of the presentation, will decide whether or not there is a role for NIRS with respect to the clinical utility in the NICU in real time. I have no relevant disclosures. And my objectives for this talk, I want to briefly review near-infrared spectroscopy technology and techniques. I want to review the normative reference data for cerebral NIRS specifically, and review current areas of NIRS research with a focus on cerebral monitoring, and then discuss the clinical utility and feasibility of NIRS monitoring in the NICU. So, as you heard in the previous presentation, there really is a need for cerebral monitoring in newborns. We know that this is a population at risk. They're at risk for intraventricular and intracranial hemorrhage, ischemic injury, periventricular leukomalacia, adverse neurodevelopmental outcomes. And then, specifically, we have our preterm infants that are at high risk, but also in our full-term babies, those that have hypoxic ischemic encephalopathy, hypoxic lung injury requiring ECMO, and then our congenital heart disease population. And so though we have wonderful technology in terms of imaging, all imaging is a snapshot in time. And what we're hoping to do with both our bundled care and our active monitoring is to identify infants at risk before injury happens and adjust our care accordingly. And so this is where NIRS technology comes in. But before we can use NIRS technology, we want to understand a little bit more about how it works. So what does NIRS measure? So NIRS is near-infrared spectroscopy. It's based on the modified Beer-Lambert law about how light is altered through the material it's traveling through. It utilizes absorption of light in the near-infrared spectrum, which is 700 to 900 nanometers. And in the spectrum, it's transparent to skin, bone, and connective tissue. And so what we end up with is a venous-weighted oxygen index of the tissue beneath the probe. And unlike pulse oximetry, it is not reliant on pulsatile flow. Commercial algorithms available use the difference between oxygenated and deoxygenated hemoglobin. And so what we end up with is a measure of oxygen uptake in the tissue bed reported as regional oxygen saturation. I'll describe it here as RSO2, but when you're looking through the literature, you may see it described in various different abbreviations. We also have seen that RSO2 can be a surrogate for cerebral blood flow with some assumptions. There needs to be stable metabolism and oxygenation. We can also combine NIRS measurement with pulse oximetry measurement to allow for identification of oxygen extraction in the tissue bed being measured, which is FTOE, with this formula as seen here. And so in this figure, you'll see that the NIRS relies on a light emitter and then two detectors, a proximal and a distal detector, to give us the information that we are looking for. And then in terms of devices available, there are lots of different devices depending on where you are in the world and what's commercially been approved. In the literature, you'll see that the most common devices are the Inros 5100C, the Nero by Hamamatsu, and the Foresight. Those are the three most commonly seen, and those are the ones approved in the USA. We also have studies out of the EU using the Oxycrem, the SenSmart, regardless of the device being used, what I think is important to understand is that though there is generally good correlation between devices, the differences in algorithms between the devices preclude comparison of the absolute measurements, or that should be done with some caution. Even within the same device, if different sensors are being used, that can lead to different reading between the sensors. So it just to be aware of as you are deciding when to use NIRS, what to use, what sensor to use, and as you're setting your goals for the NIRS measurements. And in order to use NIRS clinically, we need to know what normal is. And normative data sometimes can be hard to come by, especially in the full-term healthy population, which would be the reference population. So in adult and pediatric population, it has been referenced that cerebral NIRS generally should be within 60 to 80% with somatic measurements, which is renal, splanchnic, smooth muscle, should be around 5 to 15% above cerebral values. But is this the same in full-term healthy infants? It's a hard population to study because they're healthy. They generally aren't staying in a hospital setting where NIRS is available. But Bernal and colleagues in 2010 did do a nice study looking at 26 full-term healthy newborns that he monitored for up to 5 days. And what they found is that generally there's similar correlation to the above measures, with cerebral means being around 78% plus or minus 9%, and somatic, and they used perirenal saturation monitoring, was approximately 10% higher, just as noted above, and plus or minus 8%. They also noticed that over postnatal days, there is a decline over time. So the values generally start high, and as metabolism increases, we see a decline in the oxygen saturations, likely due to increased oxygen extraction. But what about premature infants? And we're lucky because these are babies that stay in the hospital, so we have the ability to monitor them for longer periods of time. And there was a very nice study of nearly 1,000 preterm infants, less than 32 weeks, and they established reference curves. And they did this in 2-week increments. So here I show an example of the reference curve for 24 to 25 weeks gestational age. And so as you can see, at time 0 postnatal age, the mean is approximately 63%, and then peaks around 36 hours of life, and then declines back to that initial baseline. But overall, generally, you can see that the values for cerebral NIRS are relatively steady. What we don't see that we saw in the full-term population is that steady decline over time. We also know from the study that values increase by 1% per week of gestation. There are higher values in babies who are growth restricted and in males. And that when they compared sensors, specifically one of the devices used, the Invos device, when they compared the adult sensor to the neonatal sensor based on the algorithms that were used commercially had values that were about 10% higher. So this needs to be accounted for when you're comparing data. But what about somatic saturation? There really, when looking through the literature, there isn't a lot of data. So this is, as of yet, unpublished data that I've put together of 57 infants less than 30 weeks. And what we note here is similar to what was seen in full-term infants for somatic saturation, so there's a steady decline over time. So initially, the median saturation is just over 80%, which is significantly higher than the cerebral saturation, and there's a significant decline over time. One thing that we do know is that the confidence interval in somatic saturation is wider than that in the cerebral saturation. It was approximately a 30% spread in the cerebral saturations, whereas here in the somatic saturation, you can see anywhere from 40 to even up to 50% by the end of monitoring. And so we can see that this is a tissue bed that has higher variability. And the decrease may be related to the increase in renal activity over time and may coincide with that diuretic phase that we see in most of our preterm infants. So moving on to some cerebral NIRS studies that we've seen in neonates. So this won't be an exhaustive list because of the time here, but I want to highlight some of the important studies that have been done. So what we really want, going back to the very first slide, is what we're trying to prevent. We're trying to improve our outcomes with respect to brain injury. And so can NIRS be associated and be a biomarker of impending brain injury? And so what Alger Listings Group hope to do is look at 30 cases compared to control and with very routine IVH monitoring every 12 hours. And so what they found is that prior to detection of IVH, there was a significantly higher median value of RSO2 as compared to normal controls. About 5% difference, 70% versus 65%, which may be a decrease in oxygen extraction prior as there is impending injury prior to the bleed. Interestingly, after the bleed happened, there were no significant differences noted. And so, and this is looking at that CFTOE, which is the oxygen extraction. And so you can see that the decline, there is a decline in the oxygen extraction prior to the development of IVH. So this may be something to pay attention to as we are looking in the future to use this as active monitoring. Overall, in the literature, associations with brain injury have been mixed. However, I think there is a lean towards a positive association, with generally infants with brain injury having higher saturation levels, likely due to decreased oxygen utilization in that tissue bed. And thinking about prevention, is there a way that we can use NIRS to help guide our clinical management? And so I did this study looking at nearly over 1,000 arterial blood gases with corresponding cerebral saturation data. And because we know that increased CO2 fluctuations are associated with brain injury, increased CO2 causes relaxation and vasodilation of the cerebral vascular bed. Small changes in CO2 can have a large impact on the cerebral blood flow, with up to a 30% change for 1 kPa or 7 millimeters of mercury. And so when we look at the RSCO2 percentage over CO2 categories, and I categorize these as generally low, normal, permissive hypercapnia, and high. And if you look, it's generally steady right around 70% until we exceed a CO2 of 55 millimeters of mercury. And at that point, we see a 5% increase in cerebral saturation, similar to what was noted prior to the development of IVH. And so as we are looking at continuous monitoring, if we don't have continuous non-invasive CO2 monitoring, if we see a change in our cerebral saturation, then it will give us a clue of we need to look and see what our ventilation is. Do we need to adjust our ventilator? Do we need to change our medullary pressure? Are we ventilating too much, not enough? So there's definitely areas where we can improve our management. And then another major focus of NIRS research has been in cerebral autoregulation. So we know that cerebral autoregulation is the maintenance of a stable cerebral blood flow despite fluctuations in perfusion pressure. This protective mechanism is often impaired in preterm infants. In studies, up to 40% of the time of preterm infants can be spent with impaired cerebral autoregulation. Here we see a nice autoregulatory plateau, below which we note that there's increases risk of ischemic injury, and above which the cerebral tissue is vulnerable to blood pressure spikes and hemorrhage. And we can actually measure cerebral autoregulation using simultaneous cerebral NIRS, as mentioned earlier, as a surrogate for cerebral blood flow and blood pressure monitoring. And more recently, heart rate monitoring has been used as well. So looking at cerebral autoregulation, this is a busy slide, but this is a study that we did in 61 preterm infants. And we looked at the percent time spent with impaired cerebral autoregulation. So in order to do this, there's many different ways that people have studied cerebral autoregulation and techniques, which is beyond the scope of this talk. But we use correlation analysis using a cutoff of a positive correlation of 0.5 to indicate impaired autoregulation. And so in the black, you can see impaired autoregulation. And I have three groups, one with no short-term adverse outcome, those with IVH, and those who died. And so you can see in the group that had no adverse outcome, they spent initially about 19% of their time with impaired regulation. And over the 4 days of life, that decreased to about 14%, which was a significant decline in impaired regulation. Whereas those that with injury either stayed steady or increased their time spent with impaired autoregulation. There's also the concept of reactivity, so very reactive vasoveds, so where there's an inverse relationship between blood pressure and cerebral saturation, which would lead to a negative correlation. And similarly, we see that there's increased reactivity, which is in this light gray bar, over time in the non-impaired group. So we see that they become less impaired and more reactive to their environment. And we know that there's risks of impaired cerebral autoregulation, and many thought that this is due to abnormal blood pressure, especially in the perinatal transition zone when the risk of injury is so great. So looking at cerebral autoregulation and blood pressure, Sol and colleagues noted that increased pressure passivity or impaired autoregulation when the blood pressure was less than the 10th percentile for gestational age. Gilmore and likewise Hahn found a increasing magnitude of impairment in cerebral autoregulation with decreased blood pressure. So this is Cox, which is a correlation type analysis looking at impaired autoregulation. And similarly, they used 0.5 as a cutoff. And you can see as the blood pressure subsequently drops, you get an increasing trend towards impairment, which is something to take notice of. But what can we do with this information? So one thing that we can do, because we don't have great definitions of blood pressure, is we can use NIRS to potentially define optimal blood pressure in the idea of individualized monitoring. And so here, using heart rate combined with tissue oxygen saturation, or NIRS, we see that there's this U-shaped curve where at the optimal value, we'll see the most negative value, where they're the most reactive. This is the most active blood pressure for this particular infant. And similarly, their colleagues Mitra and DaCosta also found that for preterm infants, we can identify this optimal blood pressure. And in studies with both preterm infants and with infants with hypoxic ischemic injury, it has been shown that spending time outside of your optimal blood pressure increases the risk of adverse outcomes. Now, how else can we use NIRS? So one of the big debates in neonatal care has always been the detection of the PDA and what to do with the PDA. And so we know that infants with large hemodynamically significant PDAs are at risk for decreased tissue perfusion. This is generally thought to be secondary to the left to right shunting away from the systemic circulation. There is mixed evidence to support the ability of cerebral saturations to predict significant PDA, and many have suggested that a combination of cerebral and somatic measures may be more predictive, as the renal measurements, as we see clinically with a significant PDA, are impaired before cerebral saturations. However, this next study by Lemmer's group in 2016 showed controls compared to those that were treated with either indomethacin and surgery. And they found that RSCO2 measured prior to closure, and there was a significant decrease prior to closure as compared to control in both the indomethacin and even more so in the infants requiring surgery. And then they looked further at what this means for the developing brain. And they found a significant correlation between these values of cerebral saturation and cerebellar volume. So the lower the pre-closure cerebral saturation, the lower the cerebellar volume, which then leads to developmental disabilities later on. And then blood transfusion is another area in which there's debate. Do we use high goals? Do we use low goals? And using NIRS to look at tissue perfusion, specifically cerebral perfusion with varying hemoglobin levels, we generally see a decreasing cerebral NIRS saturation with increasing anemia. And we have noted in several studies that PRBT transfusion increases cerebral saturations and decreases the tissue oxygen extraction and calms that tissue bed. Though these changes may be transient, it is striking here. It's hard to see, but this is a hemoglobin of less than 6. You can see that 1 hour and 24 hours after transfusion, there's a significant increase in cerebral saturation after the transfusion. Similarly, increases noted at levels of 6 to 7 and greater than 7, but none so striking as when the hemoglobin is so low. And then other populations, a lot of research has been done in hypoxic ischemic encephalopathy, and we have seen that higher cerebral saturation values during the first 24 hours of life have been associated with increased risk of brain injury. Infants with adverse outcome are more likely to have impaired cerebral autoregulation. And then combined with somatic and EEG monitoring may have increased value. And here you can see the infants without brain injury and those with, and you can see in this first 24 hours, there's that decreased oxygen utilization in the brain here. And then taking all of this and looking at prospective management, and that's what we want to do. We want to take this from, observational studies and looking back at the data to can we actually incorporate this in real time. And so Pitchler's group is looking at cerebral oxygen saturation to guide delivery management. And in this small initial pilot study, they found that randomizing to NIRS and the DR decreases the burden of cerebral hypoxia in the delivery room. However, they did not see any difference in short or long-term outcomes, but they were not powered to do so. And so currently they're undergoing a multinational, multi-center trial, randomized control trial to look at this on a larger scale. And then one of the most well-known studies for cerebral NIRS is the SAFE-BOO-C, where they randomized 166 ELBWs in the first 72 hours to NIRS monitoring. And they had a saturation goal of 55 to 85%. And they did show a decreased burden of hyper and hypoxia in the group, the intervention group. But unfortunately, there was no difference in clinical outcomes. And so they also, too, are conducting a larger study to see, to increase their power, as they weren't powered for those outcomes. But you can see that in the NIRS group, they kept a tighter range of cerebral saturation. And then can maintaining stable cerebral saturations improve hemodynamic stability? So they monitored 98 infants randomized to NIRS or standard care, and they found that the decrease in hypotensive burden was not significant, and there were increased echo evaluations and interventions in the NIRS group. So I think this, opens a little bit more question of that utility. And then as a real-time trend monitoring, this is from the Journal of Critical Care and looking at an infant with congenital heart disease. And you can see here, they noted mediastinal tube bleeding and then decompensation. But you can see here, both the the somatic and cerebral saturations were dropping at least 15 minutes prior to this event. And similarly, here, when the sternum was closed, you can see a very significant drop in the somatic saturation, which was increased with resuscitation. So the main thing to note is, what do we do with these numbers? If we have NIRS monitoring, but nobody pays attention to it, nobody does anything with it, then there's no utility in it. So with the Safe Through C trial, they had a very stringent treatment guideline. So when the saturations were low, they were instructed to assess cardiovascular status, potentially obtain echocardiographic imaging, consider treating the PDA, assess for anemia, assess their mean airway pressure. And similarly, when the saturations were above the limit, they looked at to assess their respiratory status and assess their blood glucose levels. And so whenever you're thinking about incorporating NIRS, there are multiple considerations for routine use. So the cost, it's expensive technology, and so it may not be feasible for all institutions. There is increased monitoring burden and alarm fatigue. So going back to the previous talk, we're trying to be very gentle in what we do to these tiny babies, and putting multiple sensors, which can interfere with care, is that helpful? And then real estate. So this is a picture from a review by Marin and colleagues, and you can see these sensors are relatively large, even the smallest sensors for, imagine an ELBW baby with this many sensors, along with their umbilical lines and their EKG leads. And so it really becomes that the baby is then covered with sensors. There also has to be staff education regarding notification and treatment guidelines, so that they know what this means. What do these measures mean? What am I looking for in my shift? So I think education is extremely important in using this in real time. And then improving real-time monitoring. So you want to have individualized patient monitoring and goals. You want to be able to incorporate a visual trend display in a user-friendly format. Right now, if it's in a small box off to the side and nobody's paying attention to it, it's not as useful. And how is it incorporated into our medical record and charting? And then ideally, what we should do in utilizing this technology is the creation of algorithms for as an early warning sign and to guide an approach to care. What I envision is having real-time knowledge of changes in cerebral blood flow and autoregulation, and potentially a green, yellow, red zone. So if they're in the red zone, avoid any elective procedures, avoid blood draws at that time, be hands off, versus if they're in the green zone, then that's a time for cares. So just going to that that gentle patient care and individualized monitoring. So in conclusion, I think NIRS should be incorporated thoughtfully into patient care, keeping in mind monitor fatigue and sensor burden. There should be clear saturation goals, absolute values similar to the safe foods, but also trend monitoring, because if you go back to the studies, many of the differences were within that wide range of values. And education on treatment algorithms is essential, and then you need to reevaluate the use of guidelines regularly. And these are my references, and thank you so much for the opportunity to share my thoughts with you.